So we conducted a study looking at actually optimizing management of Nivolumab and Ipilimumab in patients with advanced renal cell carcinoma. This was a response-based phase 2 study. And really where the genesis for the study came from is over the last over a decade now, the treatment landscape for advanced RCC has been rapidly evolving with the advent of immunotherapies, initially as single agents, with Nivolumab being approved in 2015 for VEGF pretreated patients, and then Nivolumab and Ipilimumab being approved in 2018 in the frontline setting. And we've seen tremendous efficacy with CheckMate 025, objective response rates on the order of 23%, and in the treatment naive setting, objective response rates on the order of 39%, with complete response rates around 11%. Now, with that improvement in efficacy, we've also witnessed a increased toxicity with these therapies. So grade 3 treatment-related adverse events were upwards to 50%, 47% from CheckMate 214 and 21% from CheckMate 025. So we really were left asking this question of how do we balance the risks and benefits of treatment? Is CTLA-4 blockade required for everybody? Can we convert patients who are non-responding to Nivolumab to responders with the addition of CTLA-4 blockade? And the question about treatment discontinuation is one that is clinically relevant, and in patients who are responding to treatment, can we actually stop their therapy? And so we designed this trial really looking at trying to answer some of those questions. Patients who had advanced RCC with any RCC histology were allowed to enroll. Patients were not allowed to have had a prior checkpoint inhibitor, and they had a good performance status of 0 to 2, ECOG performance status with measurable disease. And all patients initially started on treatment with induction Nivolumab, and they underwent tumor assessments at week 8, 16, and 20. A total of 83 patients were enrolled on the trial, and depending on their response during that initial 6-month period, patients were allocated either into arm A, meaning that they had a confirmed partial response or complete response within the first 6 months of treatment. And for those who did not have a response, those with stable disease or those with progressive disease within the first 6 months of treatment were allocated to arm B. The arm A patients actually had their treatment discontinued and then were followed over time to see what happened to them. The arm B patients actually had 2 doses of Ipilimumab that was added on to the backbone of Nivolumab and then were subsequently followed. The primary endpoint for arm A was the proportion of patients with a past CR or, with a complete response or partial response at 1 year post-treatment discontinuation. And the primary endpoint for arm B was the proportion of Nivolumab non-responders who convert to PR or CR. And we looked at a lot of secondary endpoints, including safety, biomarkers of response, and resistance. In the context of this trial, patients actually underwent a baseline biopsy and biopsy at progression to try to investigate biomarkers of both response and resistance. In total, 85 patients enrolled, 83 patients were initiated on treatment. 12 patients were actually allocated to arm A, and 57 patients were allocated to arm B, and the median follow-up for the study was 19.5 months. The trial enrolled predominantly clear cell patients. Around 96% of patients had clear cell disease, 8% had sarcomatoid disease, 15% had rhabdoid differentiation, and the majority of patients were either intermediate or poor risk disease by IMDC criteria. When we look at the efficacy of induction Nivolumab, so the response within the first 6 months of Nivolumab initiation, and this is not with the Ipilimumab, just within that first 6 months, the objective response rate was 14% in the initial prior to arm allocation. And as I stated, that a total of 12 patients were actually allocated to arm A, and a total of 57 patients allocated to arm B. For the arm A patients, 5 patients, that's 42%, remained off Nivolumab at 1 year post-treatment discontinuation. For the Arm B patients, the partial response rate or conversion rate was low, only about 4%, and there was no complete responses that were observed. Of the 2 patients who converted to a PR, both were previously treated and had PD as best response to Nivolumab induction. At the time of the analysis, 54 of the 57 patients who had been allocated to Arm B had discontinued treatment, and median time to treatment discontinuation was 2.7 months. Just as a point of background, overall survival for these patients, the 18-month overall survival was 79%. When we look at treatment-related toxicity, the grade 3/4 treatment-related toxicity with the Nivolumab induction was on the order of 7%. And for Arm B patients with the combination of Nivolumab and Ipilimumab, it was 25%. And there was really no, new safety signal that was observed, from the study. The rates of treatment discontinuation were 8% for Nivolumab induction and were 19% with the Nivolumab and Ipilimumab. This was treatment discontinuation for AE. Okay. So really, to put this in context, there's actually 2 additional studies that are worthwhile mentioning. The Titan RCC trial, which was presented at ESMO last year. And really, in a nutshell, that was also an adaptive-based trial design looking at the addition of Ipilimumab to Nivolumab to see if, patients can be converted into responders if they were not responding or progressing. And what we saw was that the CR rate was low from that trial, and there was a 10% rate of rescue, so that conversion from to PR or CR with the addition of Nivolumab. My colleague, Dr. Atkins at ASCO, will also be presenting the results of abstract 5006 of a trial that's looking at this approach in the frontline space. And so really, in summary, the strategy of Nivolumab followed by Ipilimumab results in low partial responses, complete responses with a conversion rate that was 4%. Low CRs were observed with this adaptive approach. And it seems like the 2 doses of delayed Ipilimumab is really not sufficient to achieve a response in these patients, and really highlights that early Ipilimumab is critical for producing and maintaining responses in patients with advanced RCC. So we cannot recommend a strategy of Nivolumab followed by response-based addition of Ipilimumab based on the results of our study. While a subset of patients were treated with Nivolumab alone, those patients were able to maintain durable responses off treatment with a rate around 42%. Early Nivolumab discontinuation in the absence of toxicity really can't be recommended. We're certainly looking into additional biomarkers to help guide treatment and help inform really who those responders are and how we can better inform patient selection from the get-go. But this is certainly a critical trial in understanding use of immunotherapy for patients with advanced RCC.